Osgood Schlatter, this is one that's going to affect all of our patients. However, we're going to look at our explosive athletes first. These are soccer athletes that are sprinting. These are jumping athletes, whether it's volleyball, whether it's basketball, because they activate that knee extensor mechanism so frequently and so often. And unfortunately, when we look at our athletes and we look at their age group, there is a weak link, and that weak link is bone. It's not tendons like you see in an older individual. It's bone. And those muscle and tendons are stronger than the bone. So we're going to start to see at those growth plates where that epiphysis is the most is the weakest, that we're starting to see a pulling away action there.
Yeah, that growth plate is 2 to 5 times weaker than the surrounding tendon. So as our athletes are starting to develop muscles, some of them are getting testosterone running through their body, the muscles are overpowering something. It depends on what age the athlete is. If we think of a medial elbow injury, if it's a youngster, it's going to be a traction apophysitis, because that medial epicondyle growth plate is the weakest spot. In somebody who's a little bit older, it's probably the tendon. And at some point in time, that weakness shifts to the ligament, and now we have a Tommy John surgery. So depending on their age, can help us predict a little bit where the injury is going to happen. We know that 10% of athletes are going, 10% of adolescents are going to suffer from Osgood Schlatters at some point in time. Most of the time, it's not traumatic. If it comes on traumatically with a pop and acute pain, we're looking at an avulsion fracture. We're probably going to more often see, at least in our offices, a traction apophysitis, something that happens non-traumatically, slow progressive onset, and it doesn't feel good when they use that extensor mechanism.
And often these things with the presentation, you're going to see that differentiation between a long-standing dysfunction and an acute dysfunction. A long-standing is a little bit of a bump, in this case of the tibial tuberosity. An avulsion fracture, it's actually going to be bruised, and it's going to be very inflamed after that injury. So really, you can kind of get a little bit of information based on how it presents, and also the timeline based on its presentation. As far as clinical findings, we really want to look at what was injured, and then now we want to push on it, we want to pull on it, we want to tug on it, we want to compress it, just like any other orthopedic test. Make it work. And when you can make it work, you're going to find what tissue gave way to begin with. In this case, resisted knee extension. Resisted knee extension. When you start to pull on the quadriceps, what's going to give way? Is it patella tendon when we find our older people, or is it going to be that growth plate where we start to pull at it and it's going to pull away from the bone? So is it more in the tendon area that's causing the pain, or is it all the way down to that bony junction?
And the easiest way to make that work is to have the patient do a deep squat. That's certainly going to exacerbate any anterior knee pain, whether it be coming from a patellar tendon, a quadriceps tendon, or the tibial tuberosity. One thing to remember is this tip here, that usually things that protect the joint throughout the range of motion, meaning the muscles, the ligaments, and the attachment of those muscles and tendons, are going to be exacerbated during the squat. Whereas things that protect the joint at end range, like the meniscus or the capsule, are going to be exacerbated at the bottom of a squat. So our patients with Osgood Schlatters aren't going to like to get up and down. That's where they're going to have to work that tendon the most. It pulls on the tibial tuberosity, and the tibial tuberosity says, hey, I'm sick of you pulling on me. I'm starting to come off.
Yeah, so looking at those ligamentous constraints, and I always love Panjabi's model about looking at the motor control versus the passive system and the active system. We have a lot of time in our practice to treat patients, but not that much time. We really need a good evaluation to look at everything. And when you can start to piece together a lot of different information from one exam, that's where gold comes out. That's where you can actually come up with a diagnosis quickly. If you look at the model on the left here, when she stands with uncompensated Trendelenburg, a double A squat, look at those knees dive in. A single leg squat, you're gonna watch a knee dive in and poor balance. In a 6-inch step down, you're gonna see the inability to have good dorsiflexion through the ankle, poor balance, and the knee diving into uncontrolled valgosity. So looking through those exams, and obviously that was very quick. If you need more examples of that, check out ChiroUp, all the videos on there with voice to understand all the dysfunctions you can see very quickly. However, you can take this kind of evaluation. It doesn't matter how much laser you give this patient, how much rest you give this patient. The best manual therapy in the world to the quadriceps, you can get this stuff to calm down, but you can't get that stuff to build back up if you have some poor motor control. So being able to address the most important factor associated with knee dysfunction, which are the foot or also the hip. In this case, let's talk about the hip. When you start to see pelvic drop, when you start to see that knee diving in, that knee's in a very poor position, and you're going to start to see overuse injuries at an increased frequency.
So one of the things the literature has taught us is that patients who have a lateral tracking of the patella are going to have anterior knee problems. What type of problem? Well, it depends on what age they are and what tissue is weakest at that given moment. In our young athletes, it's going to be the tibial tuberosity that suffers. So anything that doesn't allow the knee to stay in a frontal plane alignment is going to make tibial tuberosity issues more likely. Anything that allows the foot to drop into hyperpronation is going to put stress on that tibial tuberosity and bump those problems up. So identifying, does a patient have hip abductor weakness? Do they have foot hyperpronation is key to the assessment and the resolution, because this problem developed because the body's ability to recover was exceeded by the stresses placed upon that body. At any time we stress a tissue, whether it be our bicep, as long as there's a recovery period, things turn out well, it comes back stronger. If we stress our heart through exercise, as long as we give it a chance to recover, it comes back stronger. But what happens when you stress a heart constantly? Well, somebody has a heart attack when they're under stress on a constant basis. There was no recovery time. So while their heart rate was up for an extended period of time, wasn't the same as exercise, because exercise stops and there's recovery. In our patients who have these problems of patellofemoral problems, Osgood Schlatter's disease, shin splint, Seaver's disease, there wasn't an adequate recovery period for the amount of work that was placed on that tendon. So one of our biggest jobs is to make sure we take away the stressors while they are working and then give them an appropriate amount of work. Those stressors are hip abductor weakness and foot hyperpronation.
Also think about this, that your body's natural ability to heal is dependent on inflammation. Your body is telling you through tissue sensitivity, there's a problem here. So unfortunately, a lot of people will go in and they'll get a corticosteroid injection with a kid to make sure they can make that tournament on the weekend. That corticosteroid stops the inflammatory process, limits the body ability to heal. So yes, it can get things to calm down according to the brain, but in the periphery, you're really just preventing more healing. So I'm not saying corticosteroids are bad out loud. However, in this kind of situation, it's an unfortunate situation that we have to weigh the benefit of that tournament and that 8-year-old seeing a college scout at the ball field versus the long-term success of that patient. So what can we do for these patients? The biggest thing is to educate them on what's happening with their body. Their body's trying to heal. You're not giving enough time to heal. So yes, you can do an anti-inflammatory. We can look at the research because we know there's inflammation there, but consider why there's inflammation there. We need to have rest. We need to let the body heal. So just like hip abductor weakness and what Dr. Berlesman talked about, is that we need to correct that biomechanical fault. Because unfortunately, if we don't correct that fault, it's going to come back. And the worst patient ever is the patient that you healed and is successful, and then you see them again next month for the same condition. So we really need to make sure that we address the problems, which we're going to talk about now, but we also are able to educate them and their parent on what happened in the first place.
Yeah, that's crucial, because while the Osgood Schlatter may fade out on its own, although 2/3 of these cases do not fade out, 4 years later, the patient still has pain, even if they have skeletal maturity at that point, because that pain has just morphed from one tissue, being the tibial tuberosity, to the next culprit, which the weak link in the chain after the bone fuses is going to be the tendon. So now they have a patellar tendinopathy or a quadriceps tendinopathy from the same underlying deficits. If we can address those deficits, now the patient wins, and we can do that in office and at home.
So the first thing I'm going to look at are just the muscles. You're looking at muscle balance. You're looking at joints that they move. Do you have full range of motion upon all the joints? When you look at the muscles, you're going to find that if you have one weak muscle, if you have one painful joint, through arthrokinetic inhibition, this is a big word. I can't even spell it, to be honest with you. I just learned it in school a long time ago. Not quite as long as you were in school, but close.
That wasn't invented at that time.
Exactly. Well, we wrote in pencil. Did you guys still have stones back then? Chisel?
We had stones.
One muscle doesn't work. The other muscles have to work harder. So if you lose the ability to control your knee in the frontal plane, then unfortunately other muscles have to make up for that. Now, I'm not going to tell you whether you have to do soft tissue manipulation, insuficient manipulation, some other kind of technique that's not even invented yet that you could take a weekend seminar on. I don't care. Just be good at one of them. What we know is this: manipulation when it comes to conservative, non-pharmacological, non-surgical care is awesome. Manipulation is number one. However, manipulation plus manual therapy is even better. Manipulation plus manual therapy plus exercise is even better. So let's do all those. Working on the adductors, working on the TFL are all going to be important in this, because once you have the inability to activate your quadriceps because of that pain, you're going to start to call upon friends. And the friends in hip flexion, the TFL, the anterior band, is a critical one. And then also when you get into the actual muscle, the quadriceps. So while we're going to be trying to strengthen this muscle and strengthen the muscles around it, we also need to take away the inflammation and irritation. Soft tissue manipulation of two joint muscles, phasic muscles, is often very difficult. You can use your hands, but I often use a tool. I use like a factor tool or a Grasson tool to help my thumbs, not necessarily me, overcome that. Remember, going with the actual fibers of the muscle or the tendon is anti-inflammatory. The last part is mobilization. This is one of the things that we as chiropractors sometimes just manipulate everything. Not that there's anything wrong with that, but sometimes we don't need to manipulate a joint. Sometimes there's one specific loss of range of motion. For the knee, that last bit of internal rotation to bring home that screw mechanism when you're starting to push off and gait is important. Also, the ability to have terminal knee extension. We see that more often in our knee osteoarthritis patients, but start to look for that in your adolescents. If they have the pain there, they're going to hold a little bit of flexion in their knee. It's a protective mechanism, and we can start to loosen that up as we go through treatment.
So we know that everybody has their own favorite exercises for each condition. We know that some of this is familiar, some of it's unfamiliar. So rather than go through all the exercises for the gastroc, the soleus, the hamstring, the tensor fasciae lata, and strengthening the hip abductors, we're going to give you an access to an online site that you can check out any of those videos that you'd like to look at. And Dr. Steele will show you how to do that in just a second. One of the things that we consider, though, right, is potentially a brace at the knee, brace at the foot.
Yeah, most because our friends have them, and that's the good thing. That's the truth, is that I have 3 kids who play sports, and they play sports year long, and we don't give them any breaks because that's how they earn their shelter and their food. But one thing you're going to see on the sports field in these kind of athletes is going to be that choke pad. Is going to be a brace around the patella tendon. I don't think this is a great idea, and the research somewhat supports my opinion, but that's just my opinion. And here's why, is that once you put a choke pad or any kind of a counterforce brace on the tendon, it's going to change the angle at which that tendon pulls upon the bone. Yes, that's good. It takes away their pain. It takes away the pulling on that painful tissue. However, now you're just transferring that to excess bone, or other bone, I should say, with a pediatric athlete. So that's something you want to use if you absolutely have to. But the other thing those choke pad or counterforce braces do is they create more cross-link and they compress that tendon. And now you can have a stronger tendon. They already have strong tendons. So we don't need any stronger of a tendon. We need to stop pulling at the bone. The second part of this is looking at the foot. We just talked about the hip and addressing that. We can also look at the foot, and we'll get into that at the last section with Seeber's disease. However, the speed of pronation. If we have a foot that's driving into pronation very fast, unfortunately, it puts internal spin at the tibia and also the femur, creating a valgosity movement at the knee and creating problems like we see here. An orthotic does not slow down the full rate of pronation or full amount of pronation, but it does slow down the acceleration of pronation, which can help with these patients. So it's using the tools that we have to help these patients, one, calm things down, so then we can build things back up with our exercises. And we'll give you access to all those exercises. In fact, we'll do it at the end of this one, since we did do it for that one.